Hi students, by now in female genital system we have finished the basic anatomy or the fundamentals about the internal and the external genitalia. As far the internal genitalia are concerned, we have discussed ovaries, fallopian tubes, uterus and vagina, and this was actually in our class number, I say lecture number 3, 4, 5 and 6 respectively. But the lecture number 7 we discussed the area related to the external genitalia, we call them vulva, and in the vulva we discussed many things like the labia majora, labia minora, pudendal cleft, vestibule, the various glands and ducts opening into the vestibule like the vaginal introitus, urethral meatus, greater vestibular glands and lesser vestibular glands. At the same time certain other things also, clitoris, its function and its various parts, all these things we have actually discussed here. This was the phase 1 as far as our female genital system was concerned. But you see that in our entire syllabus or our entire scheme, we have 4 phases to complete. The second phase is now the clinical correlations about all these things which you have discussed until now during our last 5 lectures. So, our 6th lecture, in fact in this lecture, which will be probably our lecture number 8. So, in this lecture we will try to focus on the clinical correlates related to all these organs. These are the most common conditions which you in fact will come across in your clinics, the problems with which the patients in fact they present. These are the different clinical conditions. These are some clinical conditions related to the female genital system, that is called the female internal as well as external genitalia. And we have selected some 20 to 25 very important conditions, very important clinical correlations related to this. Wherever any clinical correlation will actually come, you will first have to recall your basic knowledge about that organ, and then you will be able to understand and you have to explain that in a technical language. So, we have prepared here a slideshow, and that slideshow I will annotate that also during this running of these slides here. You will focus on them. You see, we will try to understand and elaborate these conditions during the slideshow. So, let us watch the slideshow about female genital system, female genital organs, internal as well as external, and clinical correlations about that. Let us watch the slideshow. Okay, now in this session, in this slideshow, we are going to discuss the clinical correlates of the female genital organs, internal as well as external. The lectures about these organs we have already discussed in previous sessions. We have discussed until now the ovaries, the fallopian tubes, uterus, vagina. These are 4 major internal genital organs, and then some other organs in the vulva. These are the external genital organs to some extent. So, we have discussed their basic features and their anatomy and all other things here. Now, in this session we are going to discuss, and we have actually formed here a slideshow related to the female genital organ clinical correlates. What conditions you are expected, you expect to receive in your clinics here. Now, for example, the one condition related to the ovary, it is the right sided hydronephrosis. Right sided hydronephrosis, you can say, because the right renal vein and the left renal vein, their drainage points are different. As far the right renal vein is concerned, it directly opens into the, or directly drains into the inferior vena cava. You can see in this diagram, it directly drains into the inferior vena cava. While doing so, it is crossing the ureter now. When it is crossing the ureter, and this thing is not present in left side. So, if there is any chance, you see that if there is any thrombosis of the right ovarian vein, it will compress or constrict the ureter, and due to the ureteric constriction, you see the ureteric constriction, there will be accumulation of urine in the kidney, and the kidney will become hydronephrotic. So, this condition will happen at the right side here, that is why we call them right sided hydronephrosis. So, condition here. So, in this case you should actually have a good view about or say good knowledge about the correlation between the right ureter and the right ovarian vein, because they are crossing each other. The vein is crossing the ureter, which is pasted against the posterior body wall, and here the renal vein, which is opening into the inferior vena cava directly, this is being thrombotic, it will compress or constrict the ureter here, causing the right sided hydronephrosis. This was the first condition that we have discussed. Another is the ovarian pain. You see, in ovarian pain, sometimes you see the ovarian pain is referred down to the inner aspect of the thigh. Why to the inner aspect of the thigh? You should have knowledge about the basic anatomy of the ovary, in which the location of the ovary was, you see, we have already discussed in the ovarian fossa. And ovarian fossa, it was bounded by the internal and external iliac vessels, but at the same time the floor of the ovarian fossa was crossed by this nerve. This is the obturator nerve. This yellow color you see, this is called the obturator nerve. Now I am painting it red. This is obturator nerve, and the obturator nerve is crossing the floor of the ovarian fossa, and when there is any affection, any problem in the ovary, it compresses the nerve, and nerve is being compressed means the main trunk of the nerve is being compressed, and this nerve, after coming out of the obturator foramen, splits up or divides into the two divisions here, the anterior division and the posterior division, passing through the obturator canal, and it comes into the thigh. The anterior division supplies the obturator externus muscle, and also it supplies innervation to the hip joint, but the posterior division, it supplies the medial aspect of the thigh muscles as well as supplies the knee joint. Similarly, the anterior division also supplies cutaneous innervation to the medial aspect of the thigh. So, that means if the main trunk of the obturator nerve, see the main trunk of the obturator nerve, it is affected. So, the patient will feel pain in the sensory distribution of the both posterior as well as anterior divisions of the obturator nerve. So, any affection related here to the ovary can give rise to referred pain to the medial aspect of the thigh, and also discomfort in the knee joint or the and hip joint also. This is a ovarian pain, referred pain due to ovarian affection, due to ovarian condition. Relation is the obturator nerve because it is crossing the ovarian fossa. Another is the ovarian carcinoma. In this condition, you see ovarian carcinoma, there are three sources of the ovarian carcinoma. Three sources. One, it is from the germ cells. These are the primordial germ cells, because ovary is filled with the primordial germ cells. This is the one source of the cancer, the primordial germ cells. One source is this. Second source is the stroma. This is the connective tissue of the ovary. See, the connective tissue of the ovary will lead to this problem also. Ovarian stroma, this can also lead here to the cancer, ovarian cancer. This is the second source. And third source is the germinal epithelium. There is a simple cuboidal epithelium, you know that is the germinal epithelium, which is a misnomer, but this is germinal epithelium, which can give rise to the carcinoma also. This is the third source. There are three sources of the ovarian cancers here. Germ cells, these are primordial germ cells. Second is the stroma. This is the stroma, this is the connective tissue. This is in the central, located in the central position. And then third will be the germinal epithelium here. So, ovarian cancers actually affect these. So, origin of this is here. The symptoms usually is a feeling of pressure in the pelvis, because it is heavy, it is having a weight. So, there is a feeling of a pressure in the pelvis, and there are changes of bowel and the bladder habits also, because anteriorly there are pressure symptoms. Anteriorly it can compress the urinary bladder, and posteriorly it can have compression on the rectum. So, it can give rise to the changes in the bowel and bladder habits also. And this because the ovary actually brings all its neurovascular bundles from the lumbar region.
So, the lymphatics of the ovary, you see that is the spread of the carcinoma of ovary or the any tumors of the ovary spread, if it is along the lymphatics, it can affect the para-aortic lymph nodes. So, the para-aortic lymph nodes will be the first lymph nodes which will be affected due to the metastasis of the cancer of the ovary. And this is same, this is the case, same cases with the testes also, because they are bringing their lymphatics from the lumbar region, and there are para-aortic lymph nodes or later aortic lymph nodes which will be affected here. So, ovarian cancer is there, and ovarian cancer or these cancers can be diagnosed by the history, the feeling of a mass during the pelvic examination. You see during examination also, ultrasound probe placed in the vagina, this can also give a good clue about the size and all these things here. Then there is a chorioembryonic antigen that is called the CA125, this is a tumor marker also, this is indicator of the ovarian cancer. Then some other protein markers, especially human chorionic gonadotropin hormone and the alpha fetoproteins. These are the two protein markers which can be detected and which indicate the presence of this tumor. Fourth condition is salpingitis. Salpingitis means inflammation of the tube, and here tube means the fallopian tube. Salpingitis, it is the tube inflammation, it is the bacterial inflammation of the uterine tube. It can be acute, which is a neutrophilic infiltration, or it can be chronic, can be tuberculosis, which may lead to scarring of the uterine tube. And when there is a scarring of the uterine tube, you see this scarring of the uterine tube, this will result into even sometimes ectopic pregnancy also, because the lumen will be blocked means it will be narrowed down, and sperms can reach there, and from ovaries you see sperms can, even through the narrowed tube, sperms can reach in the ampulla, and here the ovum can also reach in the ampulla. There will be fertilization, zygote will be formed, embryo will be formed, but when the embryo is actually 2 cell stage, 4 cell or 8 cell stage, now embryo cannot transfer, cannot in fact travel from the ampulla to the uterus here. So, at that site at the ampulla it implants, you call it ectopic pregnancy. So, acute inflammation, chronic inflammation and scarring of the uterine tube can lead to ectopic pregnancy. Fifth condition, you know that is called here is the ectopic pregnancy. Ectopic pregnancy means is a pregnancy that means implantation of the embryo at a site other than the uterine cavity is called the ectopic pregnancy. And in the 95%, in the more than 95% of cases, ectopic pregnancy takes place in the ampulla of the fallopian tube. That is why it is called a tubal pregnancy. So, tubal pregnancy, you see ectopic pregnancy almost it is the synonym of the tubal pregnancy, because almost in every case it happens in the ampulla, but in some of the cases it can happen in close to ovary, in the pouch of Douglas, in the infundibulum, in the peritoneal cavity, this can happen in the abdominal cavity, etc. here. But you see here in this case in the ampulla the embryo is implanted here. This is called ectopic pregnancy. I see. Ectopic pregnancy, we have already told you that risk factors are salpingitis, chronic salpingitis, pelvic inflammatory diseases, or any pelvic surgery that will lead to the scarring of the tube, this can happen. Clinical signs are sudden abdominal pain, last menstrual period, history will be 60 days ago there will be the last menses, means this is indication of pregnancy. There will be positive pregnancy urine test. This is a positive human chorionic gonadotropin hormone test, it will be positive, and via cultocentesis, if you will take some fluid through the posterior fornix of the vagina and from the pouch of Douglas will get the peritoneal fluid, there will be some hemorrhagic indication there, intraperitoneal bleeding will be there. So, this will indicate it is a ectopic pregnancy, and this can be even diagnosed through intravaginal ultrasound also. There is a ligation of the uterine tubes. This is one of common methods for contraception. It is a method of birth control. There are two methods here, either it should be abdominal, a short suprapubic incision is given here, or it can be even laparoscopic, where the incision is given close to umbilicus. And here you see that it will be like this here, nostril. Either it is the tube is bended here, it should be bilateral, should be bilateral tubal ligation should be done. So, here you can see it should be bended like this one way, other way will be tied and cut here and tie the cut ends, then it should be cauterized also. Cauterized means it should be cautery should be done, so that the lumen should be closed. So, these are the three ways: cauterized, tied and cut and bended. So, this is called tubal ligation here. This is one of the methods of birth control. Another condition here is the endometrial carcinoma. Endometrial carcinoma, carcinoma means it is the malignancy of the epithelium. Endometrial means the epithelium of the uterus. So, you can see the most common gynecological condition that is usually linked to prolonged estrogen stimulation of the endometrium. Prolonged stimulation of endometrium means even if as therapeutically, if you are taking, for example, if a woman is taking estrogen, exogenous estrogen, stimulation through that exogenous estrogen can also lead to these problems. Risk factors means exogenous estrogen treatment during menopause, because in menopause the estrogen is withdrawn and there are osteoporotic and other changes might take place. So, usually hormone replacement therapy, as a result, you see, as a result of hormone replacement therapy, sometimes exogenous estrogen is given to the lady, and in that case persistent exposure to the exogenous estrogen, the epithelium of the uterus undergoes changes here, and this can lead to, this is one of the important risk factors: obesity, diabetes, nulliparity, early menarche. Means in the early ages estrogen exposure is there for long period of time, it will be, or late menopause means after, if the menopause is late, means exposure to the estrogen continues for a long period of time. So, these things can lead to, these are important risk factors. So, one of the important clinical feature is perimenopausal or postmenopausal abnormal uterine bleeding here. This is one of the important clinical features. Another condition is the endometriosis. You see, endometriosis means is the presence of endometrial glandular tissue. Endometrial glandular tissue, which normally is present in the endometrium, if it is present at a location other than the uterine cavity, then you will call it, means it is outside the uterine cavity. If it is present endometrial glandular tissue, if it is present at a site other than the uterine cavity, you will call this condition as the endometrial, you call it the endometriosis. So, it will be endometriosis. Where it can be found? Usually these are ectopic sites, you see, most common site, it is 80% will be on the ovaries, you see this is on the ovaries. Then it can be in the pouch of Douglas, in the uterine ligaments, you see in the pouch of Douglas it can be. This is a rectouterine pouch, so it can be in the pouch of Douglas also. It can be in the peritoneal, pelvic peritoneum, which is covering the bladder, rectum or uterus. You see, it is covering, this is a peritoneum which is covering the uterus. You see, this is here. In the fallopian tube, it can be. In surgical scars, it can be there also. You see, there are multiple sites here. So, this will actually be there. Clinical features will be that it will, this endometrial tissue will show the same cyclical changes, monthly changes which the normal endometrium is doing. So, that means it will shed off at the end of the menstrual cycle. So, if it is present in the urinary bladder, so the blood will come in urine, hematuria will be there. There will be close to the menstrual cycle, end of the menstrual cycle, there will be rectal bleeding also. If it is present in the surgical scars, this can actually be present, even it will start bleeding from that side as well. So, these are the things here where these are one of the features you said, and during menstruation there will be even the painful menstruation also, this is called dysmenorrhea. This is one of the causes of infertility also. Pelvic pain most pronounced at the time of menstruation, when these are shed off here, when they are in a secretory stage. Now, another is the uterine prolapse, very important condition, this is called the uterine prolapse. And the uterine prolapse means the protrusion of the cervix into the upper or into the lower part of the vagina. We have already seen here that the uterus, you know that this is normal uterus in which you are actually watching here. This is part of the uterus in which you see here. See, this uterus, a part of the cervix is lying within the vagina. This is a cervical, is called the vaginal part of cervix, and part is lying above. Above means outside the vagina. That is normal position. But you see that when all the cervix, it's a descent of the cervix into the vagina, means the descent is a total. You see here, descent of the cervix into the vagina, means total cervix is within the vagina. There is no supravaginal part of cervix any longer. You will call this is the first degree prolapse. Still in the upper part of vagina, but total cervix is within the vagina. When the descent of the cervix is up to the introitus of the vagina, means it is actually coming here up to the last part of the vagina and the lower part of vagina. You will call it the second degree prolapse. When it has actually come up to the vaginal introitus, means it is the last part of vagina, the lower part of vagina. When it comes out of the lower part, even it comes into the vestibule. You see that outside here, outside the introitus, you say it is the third degree. And when the uterus is actually just outside the introitus, you say just outside the introitus, all of the uterus is not just the cervix, but all uterus is outside the vaginal introitus, total uterus. You will call it procedentia. This is the fourth degree, you say. Usually it happens when after you say after menopause, withdrawal of estrogen, weakening of the connective tissue, weakening of the ligaments, even the muscles. So, with the advancing ages also, weakness of muscles, ligaments and the fascia which are forming the pelvic floor, they become weak, they cannot hold the uterus and all these things in position. So, these conditions will actually happen here. Even some women which has the bad obstetric history also, there is a conditions this can happen as well. Symptoms are usually pelvic heaviness, pelvic pain, lower back pain and constipation, difficulty urination because of pressure over the urinary bladder or even the urethra, and there will be painful sexual intercourse also. These are some conditions which will lead to these problems here. Then is a uterine fibroid. It is called fibroid, but basically it is not a fibrous tumor, it is a tumor of the smooth muscle of the uterus or the myometrium. That is why this tumor basically is called the leiomyoma. This is leiomyoma because in that leiomyoma, stroma is in a great quantity, means fibrous tissue is too much there. That is why it looks harder and looks like a tumor from the fibrous tissue. That is why we call them fibroid. Oid means look alike. It look like fibroma, but basically it is a myoma. Sometimes it is called fibromyoma also, but usually it is a problem related to the smooth muscle, that is called the leiomyoma. Leiomyoma is the benign tumor of the smooth muscle of the uterus. Smooth muscle of uterus means the myometrium. It is the most common benign tumor. It cannot be just one, it can be multiple even at the different sites here. And you can see here different sites. Large fibroid even can lead to the bleeding. Even a large fibroid close to the cervical canal can lead to obstructed labor. Even you see there are certain sites here. You can say one side, this is here close here to the mucous membrane. You see close here to the mucous membrane, you call it submucosal fibroid, you see close to that. Then one here close to mucous membrane, but it is not just close to mucous membrane, it hangs here and it has the stalk, we say pedunculated fibroid, it sometimes fills the cavity even. Then it is in the middle of the myometrium, away from the serous, away from the peritoneum and away from the mucosa. You see it is almost in the middle, you call it a intramural fibroid. Here is submucosal, I told you. Then submucosal due to the erosion over the submucosa, or say submucosal due to erosion from the overlying mucosa can lead to here to repeated bleeding here, recurrent bleeding here. Subserosal, which is just under here, so it is so outside that it will be just under the cover of the peritoneum. This is called subserosal. Serosa means peritoneum. And here it is the subserosal in the fundal area. This is called the fundal subserosal. So these are various sites where it will be, and according to the sites, it can have the problems like, for example, it has the complications according to that. This is a hormonal, you see that due to the estrogen, more estrogen and its size grows here, and after menopause usually they regress and it is not needed to be resected here. Then another very important condition that is called cervical cancer, cervical carcinoma, CA cervix. Cervical cancer is a slow growing cancer that develops from the epithelium of the epithelium covering the cervix here. We have already told you that the part of the cervix that is gone into the vagina, vaginal part of cervix, which is called the ectocervix, and that is above that supravaginal part, that is called the endocervix. Right at the junction usually it usually occurs at the transforming zone, because the ectocervix has its epithelium, that is stratified squamous epithelium, and endocervix its epithelium is a simple columnar epithelium. And right at the junction there is a transformation, and in the transforming zone usually the cervical cancer takes place. And here there are a lot of factors which are the risk factors, but one of the factors which is usually agreed upon, that is called human papilloma infection. Long standing human papilloma infection present in the cervical area and in the vaginal area will lead here to the changes, transformation and mutation. This is called one of the important risk factors here, and screening for human papilloma virus can lead to prevention of this tumor here. Usually this cancer grows slowly though, but upward into the endometrium. It can involve the endometrium, downward it can involve even the vagina, laterally it will involve the pelvic walls and invading even behind the rectum, and in front it can invade even the urinary bladder also. So, local spread is also very important. The cervical examination, if you see in this condition, usually this tumor, if there is any doubt about this tumor or there is any doubt about the cervical changes, tissue usually it is studied. Tissue of the cervix is usually studied by a very important screening test that is called here the Pap smear. So, Papa-Nicolau smears, that is called the Pap smear, that leading to detection of the pre-malignant conditions. Even before malignancy, well established malignancy has taken place, the pre-malignant conditions can be detected by this screening test, this called the Pap smear, very famous. And in this Pap smear you see that what is happening here, spatula is placed in the external os, you see it has been placed in the external os, the spatula would has a, and then the cyto brush is introduced into the cervix and it is rotated there, so that the cellular material can be collected from the supravaginal cervical mucosa, and that material in fact is put under the, slide is actually made here, and it is put under the microscope to see the cells and see the changes in the cells here. Much earlier, even before even the cervical cancer has taken place. Then the third term, that is called hysterectomy. Hysterectomy means the surgical removal of the uterus here. Hysterectomy is surgical removal of the uterus. It sometimes it is done through abdominal wall, through the abdomen, that is called the abdominal hysterectomy, and sometimes through the vagina, that is called the vaginal hysterectomy. And very important thing here is that you see, in that case we know that from the lateral pelvic wall, from the internal iliac artery, there is a branch that is called the uterine artery that comes from the lateral pelvic wall in the base of the broad ligament and runs into the base of broad ligament in the between the two layers of broad ligament by the side of the cervix and then the uterus, and reaches up to the uterine tube here, where it supplies the uterine tube also, whole of the uterus from its side, and it gives a branch even to the vagina also. And during its course, you see from both sides it is happening like this. And during its passage like this, because from posterior wall it is coming, you see from posterior wall is coming the ureter also. So, ureter is also passing here by the side of the cervix or the lateral vaginal fornices. This is the cut section of the ureters which are coming from behind, because this is the coronal section, that is why this is the cut section of the ureter, which is actually coming from the posterior body wall. So, when this ureter is coming from the posterior body wall, this uterine artery is passing over the ureter and comes here to supply the uterus and etc. here. So, over the ureter. So, when hysterectomy is done, uterine arteries from both sides, they are ligated, and during the ligation of the two uterine arteries, sometimes by mistake the ureter can be ligated, may be ligated here, and when this ligation of ureter by mistake takes place, this will lead here to, after hysterectomy, it will lead here to the hydronephrosis. So, very important relation of the uterine artery with the ureter, and hysterectomy, one of the complications is this also. So, you can use this also. You see, in that case you are watching, in that case if you see this, there can be we call it the subtotal, one case you say it is called the subtotal hysterectomy. Subtotal hysterectomy means the entire uterus along with the cervix is actually removed. This is called the subtotal, means along with that is removed, even the cornu of the uterus is also removed. This is subtotal. Another is called the total. In the total means upper part of the vagina is a, so in this total means this entire cervix and all these parts are actually removed, but in the radical, you say in the upper part of vagina is also removed, even the left and right parametrium, this is the connective tissue and everything, and the peritoneum, this is also removed. This is called radical hysterectomy. So, another is the examination of the uterus. Examination of the uterus means you can say, you see the two fingers here, this is bimanual examination. Two fingers of the right hand, they are put into the vagina, and other hand is pressed infero-posteriorly on the pubic region on the anterior abdominal wall. And this will actually give the idea about the position of the uterus, and you know that the position of uterus is anteverted, anteflexed, means vagina having a 90-degree angle with the uterus here, with the cervix, and cervix is having a 170-degree with the body, and these positions can be detected by examination, by the bimanual examination or digital examination, you see there. Now, laparoscopic examination of the pelvic viscera, you can see ovarian cyst through laparoscope, the ovarian cyst tumors and ectopic pregnancies can be detected here. So, this is a endoscope, and this laparoscope is actually being put here. You see, this is light is thrown here and procedure is being carried out here. Here fallopian tubes, ovaries and uterus, all these procedures can be done through laparoscopic procedure, which you are watching. A small incision is given below the umbilicus. Inert gas is provided into the abdominal cavity, so that the enough space is available, and pelvis is elevated so that the gravity will pull the intestines into the abdomen to give more free space in the pelvic cavity. So, three things are done: incision in the peritoneal cavity just below the umbilicus, insufflation of inert gas into the abdomen to give more free space, and then the pelvis is elevated, so the abdominal viscera, you see sigmoid colon, other things can shift themselves into the abdomen, so that we have enough space to operate within the pelvis. See, this is the superior surface of the pelvic viscera, this is the fundus of the uterus, these are cornu, and you have, see, this fallopian tubes, and we have this ovaries, a urinary bladder. It is not just to visualize all these things, but this is for therapeutic procedures also, like ligation of the fallopian tubes, and all these things can be done, even the biopsies can be taken. There is the vaginal fistula, one of the grave conditions you see is vaginal fistula. In obstetrical trauma, or during delivery, if there is any trauma, long and difficult labor, tears in the vaginal wall lead to these problems, you see that. Because we know that the vagina is intimately in contact with the urinary bladder. I say with the urinary bladder as well as with the urethra, you see. And whenever there is and it is not just here, but it is in contact with, you say very close here to even to the rectum also. So, when the birth canal, you see during the birth canal, and when there is a passage of the head here and head compresses the interior wall of the vagina, so it will actually compress not just the interior wall, but the posterior wall of urethra also. And if it is in the upper portion of vagina, then it compresses not just the interior wall of the upper portion of vagina, but the back of the urinary bladder also. So, back of the urinary bladder and upper portion of the vagina, they can be compressed, and they can be pressed in such a way that they will undergo injury, and injury will cause here to the inflammation, the tissue will slough off, and there is a free communication between the upper part of the vagina with the urinary bladder. You see this, in this condition you are watching this. You see upper part of vagina and the urinary in the urinary bladder, direct communication has developed here. This abnormal communication, you call them fistula, because this fistula is between the vagina and the urinary bladder. That is why we call them vesico-vaginal fistula, VVF. It's called the vesico-vaginal fistula. This second one is vesico-vaginal fistula. Sometimes, rarely though, uterus can also communicate with the superior surface of the urinary bladder. This communication can develop due to the inflammation. This is called here the vesico-uterine fistula. Not that common, but usually. Or in the lower part of the vagina can develop communication now due to sloughing of the anterior wall of vagina and the posterior wall of this time the urethra. And here another communication this time can happen. This is from between vagina and urethra. This is called urethro-vaginal fistula. This is also common. The third one is this. Or if it is on the back side, the posterior wall of vagina can communicate with the rectum. If there is a pressure between the posterior wall and the rectum, so anterior wall of the rectum and the posterior wall of vagina can communicate through a communication, abnormal communication, that is called recto-vaginal fistula. Means of the recto-vaginal fistula, that indicates, that means the fecal mass will not just pass here through the anus, but some can pass through vagina also. And here the urethra or in the urinary bladder is not just urine will pass through urethra, but can pass through vagina also. So, these are some of the complaints or signs and symptoms which can be kept in mind here. So, vesico-vaginal fistula, and this will be it. If it is a vesico-vaginal fistula, there is a continuous flow of the urine. But if it is a urethro-vaginal fistula, urine will appear only at the time of micturition. This will indicate at what level the fistula is there. Otherwise, the fistula can be detected by examining the walls of the vagina here through pervaginal examination. Another thing is culdocentesis or culdoscopy. This is a culdocentesis, means to have an access through the vagina via posterior fornix of vagina into the pouch of Douglas. This is an access, and if you are visualizing or putting the endoscope here through that route, you see through that route, if you are actually putting here through the posterior fornix of the vagina, see this here, this is called culdoscopy. And if you are tapping the fluid from this pouch of Douglas, which is the most dependent part of the peritoneal cavity in case of female, so you can recover some fluid for the pathological say analysis here, and to see the cells like for example malignant cells, or say even in pelvic inflammatory diseases. So, you will actually watch here, this is called the culdocentesis, like paracentesis, pericardiocentesis, it is called the thoracocentesis, like here it is called culdocentesis here. Another is vaginitis, means inflammation of the vagina. When the vaginal, otherwise the vaginal epithelium is resistant to bacteria, fungal and protozoal invasions. Usually the pathogens remain within the vagina and they do not affect, they do not cause any harm to the vaginal epithelium here because of its acidic pH. But if vagina epithelium is involved, we call them vaginitis, but mostly it is a protozoal, that is called Trichomonas vaginalis, it is a protozoa. 15% cases is this. Another is the Candida albicans, this is a fungus, 25% this fungal infection and 30% is this bacterial infection. Now, vaginal examination is an examination of the pelvic structures through the vagina, this is called vaginal. You can see here in this condition, inspection with the speculum, it allows the observation of the vaginal walls. You can see posterior fornix, you can do cultocentesis, you can do even to visualize the external os, uterine cervix position or the condition of the uterine cervix. All this is done through speculum. This is PV examination, this is per vaginal examination through speculum, it is actually done. Another is digital examination. Urethra and bladder can be digitalized, can be actually seen or palpated from the anterior fornix. This can be through anterior fornix. Perineal body and rectum, sacrum, they can be palpated through posterior fornix. And ovary, uterine tubes and the ischial spines can be felt through the lateral fornices. You see anterior fornix, you can feel urinary bladder, urethra. Posterior fornix, you can feel rectum. And from lateral fornices, you can feel the ischial spine, fallopian tubes, uterus, etc. And ovaries also. Another bimanual examination that we discussed previously, fingers of one hand is passed, right hand is passed through the vagina and left hand is put over the pubis and inferior posteriorly it is pressed here. This is bimanual examination, you say. Then is called vaginismus, we call them. Vaginismus basically is a painful spasm of vagina resulting from involuntary contraction of the vaginal musculature that prevents sexual intercourse. This can be organic or can be even psychogenic also. Usually what happens is this actually cycle of pain is like you say the body anticipates pain, fear, anxiety that contributes in body is automatically you see reflex contraction of the muscles, vaginal muscles will become tightened and this tightening or tightness will cause the sex painful and makes the penetration impossible almost. And due to the pain there will be reinforcement or intensification you see of the reflex response, more contraction, body reacts by bracing more on ongoing basis here you see, and then usually there will be avoidance of intimacy and lack of desire for even sex. This is called vaginismus. And this happens either it can be organic or can be even psychogenic. Maybe there are certain organic problems here in the vagina and the uterus or it can be even psychogenic trauma, traumatic experience like rape or like sexual abuse. Women becomes try to actually avoid this intimacy because of this mental trauma. Now this is the term that is called the episiotomy. Episiotomy is basically surgical incision through the perineum, through the wall of the vagina to increase the size, I say increase the diameter of to enlarge the birth canal so that the head can easily pass through when there is any chances of obstruction of labor. So if there is any problem or delay in the second stage of the labor, usually episiotomy is done. It allows a greater expansion of the birth canal. Now in this case there are two types of episiotomies. One is called the mediolateral episiotomy. In this case you see mediolateral. This is a mediolateral, this one is mediolateral and this is midline. This is mediolateral. Now in this mediolateral especially you see incision is given through the posterolateral wall of the vagina, posterolateral wall of the vagina, lateral to the perineal body, that will avoid the perineal body, and it will cut the posterolateral wall of the lower part of vagina to increase the vaginal introitus. It allows greater expansion of the birth canal into the hysterectal fossa. There is however, increased risk of infection because of the contamination of the hysterectal fossa, but usually in this advantage will be, and advantage here is that perineal body and external anal sphincter and all these things can be saved. But this is called midline, this one is the midline episiotomy. You see it is coming towards the perineal body and external sphincter also. So, this midline episiotomy or median episiotomy, posteriorly it is the midline through the posterior wall and central tendon of the perineum, that is called the perineal body. Usually it is bloodless, painless. It provides a limited expansion of the birth canal. The previous one was more, but this one you see it is expansion is, though it is relatively bloodless and painless, but the expansion of the birth canal is limited, and there are chances that the perineal body and external anal sphincter can be injured also. So, usually more preferable episiotomies nowadays is these, it is called the mediolateral episiotomy. Another the condition is called the Bartholin cyst. Bartholin cyst means it is due to the inflammation of the greater vestibular gland. Greater vestibular gland, you know that is lying actually in the superficial perineal pouch in case of female, within the bulb of the clitoris, bulb of the vestibule you call them. You see here it was a say pelvic diaphragm, vagina comes out of it. This is urogenital diaphragm, vagina comes out of this also, and when it comes out here you see it comes here on the two sides there are bulbs, these are called the bulb of the vestibule, surrounded here by bulbospongious muscles, and within the bulb they are lying the greater vestibular glands, bulb of the vestibule, and here they have the ducts which are opening here just at the end of the vagina, not in the lateral wall of vagina, and here is the hymen, and you say it is the ducts, now ducts they are opening here. And these glands usually, if the ducts are blocked here due to some inflammation or other things, these glands in fact will undergo enlargement, secretions will stay there and will accumulate there and they will become cystic. You call them cystic appearance, you call them cyst, and this is the greater vestibular gland cyst. The greater vestibular gland's other name is the Bartholin gland, that is why we call them Bartholin cyst. So, obstruction of the duct from the greater vestibular gland will lead here to this problem. You see this is here the problem, see this is labia majora and these are labia minora. Space between the labia minora called the vestibule, and in the vestibule there is opening of the vagina, and just anterior to that is the urethral orifice, and anterior to that all of them is the clitoris. So, you see here there is a swelling because the greater vestibular Bartholin glands have got accumulation of the fluid, inflammatory fluid because of blockade of their ducts here, very painful condition, and the symptoms you see that will be dyspareunia or painful intercourse, and obviously if it is acute you see that here the location of the gland here, the Bartholin glands, the opening into the side of the vagina, not in the lateral wall, outside lateral wall. Another term that is called hysterosalpingography. Hystero means uterus, salpingo means the tube. Hysterosalpingography means it is the visualization or the radiographic procedure involving the injection of water soluble radiopaque material into the uterus, through the vagina into the uterus, that will pass into the fallopian tubes and pass through the infundibulum, and it will come here into the peritoneal cavity, because you know that the peritoneal cavity in case of female is open to outside here. and here this is radio-opaque dye, and radiographic exposure is taken. You see the X-ray films are formed here, X-rays are taken, and you see the patency of the vagina as well as you see patency of the uterus, and the lumen of the uterine tubes can be visualized through that. You see in this condition, it has been put here, you see this dye has been put here. Uterus, you see the lumen of the cavity of the uterus, and on both sides in the fallopian tubes they are going, the dye is going in both of them, means both the fallopian tubes are intact. So, this is open fallopian tubes, but on this side you see in this diagram, uterine cavity is there, means it is patent. On one side the fallopian tube's lumen can be shown, on the other side some part of the fallopian tube lumen can be shown, but the remaining is not, is blocked. I mean this is blocked fallopian tubes on the left side. This is called hysterosalpingography.